Welcome to another CME podcast episode from NEI, the Neuroscience Education Institute. In today's CME episode, Dr. Andrew Cutler will be interviewing Dr. Vladimir Maletic about novel agents in development for major depressive disorder, or MDD. For complete CME information, please refer to this podcast description page or go to nei.global/podcast. Let's listen in as Drs. Cutler and Maletic discuss the current research findings on exciting and novel treatments for MDD.
Hello and welcome to another NEI podcast. This is a CME podcast, and I'm Dr. Andy Cutler. I'm thrilled to be here today with a very good friend of mine and someone who I think goes without saying is really one of the world's authorities on depression, the treatment of depression, and the neurobiology of depression. And our topic today is novel agents for treating major depressive disorder. And I'd like to welcome my friend Vlad Maletic. Vlad, how are you?
I'm great, Andy. Thank you very much, and thank you on your very kind introduction.
Well, it's certainly true. I would like to get started here by setting the frame. Vlad, when you and I trained, it was the dawn of the second wave of modern psychopharmacology. You know, I like to think the first wave was the 1950s. We had first-generation antipsychotics. We had tricyclic antidepressants. We had monoamine oxidase inhibitors. And then in the late 80s, early 90s, I think we hit the second wave, which was SSRIs, SNRIs, second-generation or atypical antipsychotics. And now I think we're on the cusp of the third wave, which is going beyond monoamines into mechanisms of action such as glutamate and GABA. And our audience may be familiar with the recent big news, the announcement of a second positive study with a novel antipsychotic that uses a muscarinic agonist mechanism. So it's a really exciting time, Vlad. Wouldn't you agree?
I would absolutely agree with you, Andy. I think it's really time that we start looking beyond monoamine modulating antidepressant agents, especially since there are some advancements in understanding neurobiology of MDD that indicate that there may be other neurotransmitter systems that are involved.
Yeah, the monoamine hypothesis has come under some degree of scrutiny and controversy, I would say, lately. You and I have recently, of course, seen the article that came out really throwing into question, especially the serotonin theory. But we're talking about an illness that's very heterogeneous biologically and clinically. So to think that there's one unifying theory, maybe that's a little naive.
I absolutely agree with you, Andy. I'm aware of the article that you're mentioning. And there they look at various indicators of abnormal serotonin transmission in a major depressive disorder and suggest that there are not sufficient data indicating that serotonin indeed plays a role. I think that there is a logical issue with that because the assumption, even if there is not any serotoninergic disturbance, and as you said, this is a heterogeneous condition, so we can't take for granted that is the case in every single individual who has major depressive disorder. But even if, let's say, there is no clear indication that there is abnormal serotonin transmission in MDD, it still does not mean that serotonin modulating agents wouldn't work. It's very naive reasoning, Andy, because very simple reason. We know ECT works in MDD. Does that mean that patients who have MDD have voltage deficiency? I mean, right?
Yes.
Yeah. So in other words, I would not make a conclusion that just because there is dubious evidence of serotonin involvement, etiology of MDD, that therefore serotoninergic agents will not work.
Yes.
So I think that's an important takeaway. The other thing that is really not as well known, but looking at the studies that focused on neurobiological, biochemical indicators of disease state of MDD, they're very different than indicators of response to antidepressant treatment. So maybe the biological footprint of disease state is not necessarily an indicator of response to treatment.
Very interesting. Of course, it's also possible that manipulating monoamines starts a cascade, if we will, or starts a process of things that start happening downstream. And then ultimately, there is a therapeutic process that happens. And this could explain why, for instance, it can take several weeks for these monoaminergic drugs to work.
Oh, I absolutely agree with you, Andy. So very briefly commenting on the whole monoamine story, there is something that is concerning. Namely, if we look at the meta-analysis of cerebrospinal fluid levels of all monoamine metabolites, there is no conclusive evidence that there's abnormality in serotonin and norepinephrine in individuals who have major depressive disorder. That is true. But you're making a very good point. Serotonin and norepinephrine receptors are located both on pyramidal neurons in the prefrontal cortex and also on various types of GABA interneurons. These pyramidal neurons and GABA interneurons constitute probably what we can think about the main processing chip in the prefrontal cortex. And whenever we manipulate serotonin and norepinephrine, we're indirectly manipulating that micro unit in a prefrontal cortex and therefore changing GABA glutamate balance and then downstream glutamate input into brainstem serotonin, norepinephrine, and dopamine nuclei. Therefore, if there is something abnormal with GABA glutamate microcircuit, it will be manifest as if there is some problem with monoamine signaling stemming from brainstem.
I see. So what you're saying is we're talking about pyramidal glutamate neurons and GABA interneurons. So really the brain is a yin and yang, isn't it, between the excitatory glutamate and the inhibitory GABA?
In every possible way, in some ways that we didn't even think about it. So not only is it a balance between principal excitatory neurotransmitter and principal inhibitory neurotransmitter, believe it or not, they also regulate inflammatory signaling in the brain. Increased excessive glutamate tone tends to be pro-inflammatory. On the other hand, increase in GABAergic transmission tends to have an anti-inflammatory effect. That opposition between these two neurotransmitters, yes, in regulating brain circuits, it's very important, but it also regulates other neurobiological processes in the brain.
This is fascinating. I think back to when I trained, we used to talk about the neurobiology more like there's a part of the brain that's not working properly, or there's a part of a brain responsible for depression. I think we've gotten so much more sophisticated now in talking about the circuitry and the networks.
You're absolutely right, Andy. If we try to extract some useful information from neuroimaging studies, functional neuroimaging and structural neuroimaging studies, what it points to is that the relationship of symptoms to MDD is not really related to any specific brain area. It tends also not to be related to a specific neurotransmitter system. It relates more to the relationship between these major functional networks that you mentioned. And these include, I'll just list them, I will not get into details, but default mode network, salience network, sensory motor network, and central executive network. Those are some of the ones.
Yes, absolutely. So it's really about modulation, regulation, communication between these various parts. And if you think about it, it's all pretty darn complicated, and it's easy to see how it could get out of whack.
You're absolutely right. The more complicated the system is, the less it takes to take it out of balance. Yeah. So you're absolutely right. There can be minute effects that will unbalance the system, and that will eventually lead to clinical manifestations.
Okay, let's talk about the clinical manifestations and the clinical relevance of what we've been talking about. And I just want to put in a plug, Vlad, if I could, for your book. Vlad has written the definitive book on the neurobiology of depression. It's called The New Mind-Brain Science. And so I highly recommend that. You wrote that with your friend Chuck Raison.
Thank you very much, Andy. And I also want to mention, I'm sorry that I'm mentioning this, but there is a more concise and updated version. So Drs. Hayes, Raison, and I were involved in writing writing a chapter on neurobiology of mood disorders for Sadok and Kaplan, comprehensive textbook of psychiatry that will be due out this fall. So there will be actually an update to what was in the new Mind-Body Science.
Well, I can't wait to see that, so thank you. Let's again move into the clinical relevance for our audience, most of whom are clinicians. We've alluded to this, Vlad, but why is it important that we develop antidepressants with novel mechanisms going beyond this traditional monoamine mechanism?
I will just briefly mention two bodies of data that provide very interesting information and to a degree an answer to your question. So starting with STAR-D, we see that there is progressive loss of remission rates as we go from one monoamine modulating strategy to the next. So in the first step of STAR-D, I'm just rounding off the numbers, we may have about 35% remission rate. By the time we get to step 4, it is a roughly 13-14% remission rate. You know, there is something that is beyond that, Andy, and that is that remission is not sustained over 12 months. So in the first step, roughly 65 to 70% of these who remitted will remain remitted by the end of 12 months. Step 4, 13% remitted. By the end of 12 months, that will shrink down to less than 4%.
Oh, my goodness.
In other words, it's not only achieving remission, it is sustainability of remission that deteriorates with every step of STAR-D. The other part that is equally, if not more disturbing, comes from a large study conducted in Netherlands. It included over 900 individuals. And they looked at the outcome after first 2 years of treatment of MDD. And it looked pretty optimistic. About 50% of these individuals achieved remission, and only about 20% had chronic depressive symptomatology, chronic being about 2 years or more. If you flip the script and go to 6 years now, 6 years out, here's what happens. 6 years out, 50% of these individuals now have chronic depression, and only 20% have sustained their recovery.
Oh, boy. That doesn't sound very good.
No, it does not sound. And in terms of functioning, the ones who have chronic illness versus the ones who recovered have roughly 4-fold greater impairment in functioning.
Wow.
A lot of suffering associated with this condition, with the treatments that are a mainstay of depression treatment right now.
So I guess people believe these drugs work because they're the best that we have, but clearly they're inadequate. Clearly not enough people are responding, and certainly not enough people are getting a full recovery or full remission, and certainly less even have enduring or sustained recovery. This is not good.
Indeed. And we're seeing it even takes longer to achieve remission. In individuals who had to go to step D of STAR-D, more than 45% of them needed more than 9 weeks to achieve remission.
Right. So depression begets depression, it sounds like.
Indeed. So I think what we're beginning to guess, Andy, and I don't know if you would agree with this, if we're not getting response to monoamine modulating antidepressants with first 2 appropriate antidepressant treatment attempts, so appropriate duration and appropriate dosage of antidepressant utilized, I think we're looking at diminishing returns beyond that point.
Yeah, I would 100% agree. And I think another way of thinking about this is if you're not seeing some degree of response within the first 2 weeks, you probably need to adjust what you're doing, whether that's raise the dose, switch, augment, something. Yeah, that's something rather than waiting weeks upon weeks, because as you've said, it's almost as if a scar forms in the brain or something. It makes it harder to treat.
It's interesting because there's a French group of researchers who actually defined it exactly that way. And they were specifically talking about cognitive difficulties in individuals. And it's very simple trail-making test B in individuals who have MDD. First and second episode, once they're in remission, they recover. If they've had 4 or 5 depressive episodes, they actually call it cognitive scar.
Oh, my goodness.
And there are imaging studies that show that unless we're successfully in attaining remission, gray matter volume changes occur in critical parts of the brain. We're talking about hippocampus, amygdala, dorsolateral prefrontal cortex. They're actually gray matter volume trophic changes in these parts of the brain.
So this is a new concept probably for a lot of our audience. What we're saying is, in some ways, this may be a neurodegenerative or neuroprogressive illness like we think about schizophrenia or even bipolar disorder.
Andy, I would agree with you. There are changes in gray matter volume, and these are neural cells Well, the evidence, interestingly enough, does not implicate neurons as much as it implicates glia cells.
Okay, that's a very important distinction. I appreciate you saying that.
Of course. So it seems that MDD is the first order of gliopathic disease, although there are some changes in neurons as well.
Yeah, and this is, of course, I think, very important and newer thinking for much of our audience. So I guess what we're saying is the motivation here to go beyond monoamines is that the monoaminergic drugs, they ain't so hot. They don't work so great. I mean, when they do work for some people, as we know. So we need drugs that are going to work more broadly for patients. But also, this new generation of treatments we're talking about have more rapid onset of action. And that can be very important.
Which could mean that we are more proximal to the cause of the illness.
Exactly.
I think it's good to mention, I'm going to try not to be too nerdy about this, but there are a couple of really large studies, and one of them is Enigma Project. And in this particular study, they studied over 20,000 patients who have MDD. And it's a cross-referencing approach to studying major depressive disorder, in that many of these individuals were genotyped. They did functional and structural imaging on thousands of individuals. They did postmortem studies on brains that came from brain banks. And it's interesting what they found in areas of the brain that differentiate individuals who have depression versus not. Transcriptional signatures suggest, number one, involvement of astrocytes. Number two, of somatostatin expressing GABA interneurons. And number three, glutamate pyramidal neurons. This was replicated in completely independent sample study done in Asia. Pretty much the top three are the same.
Wow.
So it's actually, it's astrocytes are number one, but if there are nerve cells, there'll be GABA interneurons and pyramidal glutamate neurons.
Wow. So that brings us back to GABA and glutamate. Let's talk a little bit about the glutamate system and how glutamatergic neurotransmission may be involved in the pathophysiology of depression and why that would be a reasonable target.
So we do actually have very interesting studies. So if we compare individuals who are experiencing their first depressive episode, even when they recover from their first depressive episode, using magnetic resonance spectroscopy, to evaluate GABA and glutamate signaling. Again, not the most precise measure, but an important indicator. Here's what we're finding. Even the ones who recover after first depressive episode and in the midst of episode don't have major differences in glutamate signaling from healthy controls. On the other hand, individuals who have chronic depression do. So early in the course, we do not see prominent glutamatergic abnormalities in medial prefrontal cortex, one of the key areas involved in emotional regulation. But in chronic depression, there is. And there is another study that looked at duration of major depressive disorder, essentially found the same effect. Early in the course, we do not see major glutamatergic abnormalities in some of the key brain areas involved in regulation of mood. But with the duration of illness, we see more and more. So again, talking about the scar, there seems to be a neurochemical scar as well, Andy.
Yeah. So the clinical implication of that, does that mean, Vlad, that the newer glutamatergic agents such as ketamine and others in development should be reserved for later in the illness, or we should try other things first for the first or second episode and then use these? Or is that too simplistic?
Yeah, it's an excellent question, Andy. And unfortunately, we really don't have reliable data to answer it.
Yeah.
I think in my mind, what would be worth doing, okay, if we still have chances of achieving some benefit with monoamine modulation, let's give it a shot, see if it's going to work. If not, let's not have patients fail 3 or 4 treatments. Again, the likelihood diminishes with each attempt. Let us step in with medications that modulate glutamate and GABA earlier in the course and see what happens. Is that going to change the course? Maybe it will, maybe it won't, but we probably need to know the answer to that question.
No, I love that question, and I love that way of thinking, because I always say when you're banging your head against the wall, and it hurts. Stop banging. Don't bang harder. Don't keep using monoamine after monoamine after monoamine. And yet large prescribing databases suggest that's what we do. We go SSRI, SSRI, SNRI, SSRI. We go 4 or 5 lines of these things before we consider doing something different.
Absolutely.
That doesn't seem to make sense. And part of that is we didn't have options, but I think we do now. Before we get into some specific options, let's do the yin to the yang here. Let's talk a little bit about the GABA system and how that may be involved in the pathophysiology of depression. Why is that a target we should be looking at?
Well, Andy, we really have very good evidence implicating beyond the transcription evidence that comes from these large databases. There's also evidence that GABA neuronal density and, again, dorsolateral prefrontal cortex, part of the brain that has to do with cognition and executive function, is reduced in depressed patients relative to control. Another part of the brain that has a lot to do with emotional regulation, anterior cingulate, there is a disturbance in GABA signaling in patients who have treatment-resistant depression, but not in the ones who don't have treatment-resistant depression. And finally, data that suggests abnormal GABA signaling in hippocampus, a key brain area involved not only in short-term memory, but also hypothalamic pituitary adrenal axis regulation. We do see very often HPA abnormalities in depressed people. Big question is, might they be downstream effect of abnormal GABA signaling, for example, hippocampus and anterior cingulate cortex? A lot of interesting questions there. And again, another clinical correlate of abnormal GABA signaling, especially in younger patients. I know you treat younger patients quite a bit. It correlates strongly with intensity of anhedonia in depressed youngsters.
Yeah, there's also a correlation, isn't there, with anhedonia and inflammation as well?
You're absolutely right. Inflammation kind of reroutes signaling in the brain.
I see.
And the areas of the brain that are there to monitor changes in the environment are on the high alert. And it correlates with clinical manifestations such as scanning the environment, apprehension, anxiety, negative emotional tone. On the other hand, reward signaling, interest in pleasurable activity, exploration, diminishes. Ventral tegmental area connected with nucleus accumbens, those are some of the major dopamine pathways that regulate reward signaling, have diminished activity in face of inflammation. You're absolutely right.
So depression clinically is both an increase in vigilance, but also negative mood. You're more depressed, sad, anxious, but also a decrease then in positive tone or positive mood, pleasure.
Yeah, and it's very interesting, Andy. There are longitudinal studies that have looked at that, and that is exactly what happens with repeated episodes. With repeated episodes, opposite of the song title, we accentuate the negatives and minimize the positive.
Yes. So that's the negative cognitive bias that is well described. Okay, we've talked about glutamate and GABA. It turns out there's a couple of other targets now being looked at. And one of those, of course, is everybody's aware of the psychedelic drugs. And what they seem to have in common is agonism of the serotonin 5-HT2A receptor. How could that possibly be helpful for depression?
It's interesting, Andy. I would say that at the first level, indeed, there are serotonin 2A agonistic agents. But on the other hand, we also have to wonder where those serotonin 2A receptors are. And at least when it comes to the prefrontal cortex, these 2A receptors are in layer 3 pyramidal neurons. Yes. And layer 5. So 3 and 4 and layer 5 pyramidal neurons. So when we activate those serotonin 2A receptors on layer 4 pyramidal neurons, what it means is increased glutamate output. Where does some of that glutamate output go? It goes to layer 5. And then we have direct impact of serotonin 2A agonism on layer. So in some ways, it is increasing glutamate signaling plus gain. So ultimately, serotonin 2A agonism in the prefrontal cortex translates into double enhancements of glutamatergic transmission. It is a different mechanism, but when we look at the downstream effect, much of it has to do indeed in changing the balance between glutamate and GABA in the prefrontal cortex.
I see. Yeah, and certainly doing that, you would also increase dopamine tone in the motivation reward system, as we talked about. So that's
absolutely correct. That there's evidence to indicate exactly what you said.
Yeah.
That as a correlate, there is increased glutamatergic transmission. And interesting, we spoke about networks. There is increased connectedness in functional networks as a result of use of psychedelic agents.
Yeah, and I would imagine that could lead to improved cognition as well, which is
possibly so. We need better studies to determine that, especially longitudinal studies, but it is clearly a possible implication.
Okay, so we're going to talk a little more about psychedelics in a minute, but let's go to our fourth mechanism, our fourth target, if you will, and that's the opioid system. How could that be useful in the treatment of depression?
Andy, we don't have nearly as many studies looking at opioid signaling in depressed patients. One of the studies has found a decreased mu opioid receptor signaling in women who have MDD, and interestingly enough, it again correlated with treatment resistance. There are some studies post-mortem that are finding abnormalities actually increase kappa opioid receptor activity in expression of those receptors in individuals who had MDD and are now deceased. Mm-hmm. So there is some neurobiological evidence implicating disturbance in opioid signaling. But when we're speaking about opioid, there's a couple of things to keep in mind. Mu receptor modulation would probably help depression a little bit, but then we're carrying the risk of addiction and possible overdose and respiratory suppression.
Right.
Kappa opioid system is clearly detrimental because kappa opioid receptors in ventral tegmental area, this is the origin of dopamine, many dopamine fibers in the brain. Kappa opioid signaling suppresses dopamine transmission.
Right.
And therefore, blocking kappa opioids might be harmful.
Yeah, there are kappa antagonists actually in development, to your point.
Absolutely. Yeah. Absolutely. Yeah. And then there are also delta opioid receptors. Their activation is believed to be anxiolytic and antidepressant.
So agonism of mu and delta might be beneficial, whereas antagonism of kappa. So it's a little bit different. Historically, Vlad, morphine and buprenorphine have been reported to work for depression and have historically even been used for depression.
Indeed. And as there was a combination of buprenorphine with samidorphan, which is a mu opioid mostly antagonist. Yes. And it did show some early promise in treatment of MDD.
It did, and I was involved in those studies, and I was disappointed, as most of us were. What was interesting was, so buprenorphine is both a mu agonist and a kappa antagonist.
Indeed.
And what was done here was samidorphan is a mu antagonist, and so the idea was to blunt the mu agonism for the very reasons you talked about that could lead to trouble, but then allow the kappa antagonism to shine through. I don't think it didn't completely suppress mu, however, so there's a little touch of mu and a kappa antagonism, and that's a fascinating mechanism. Of course, there's also the controversial study that was done out of Stanford that part of ketamine's mechanism of action may be through the opioid system as well.
Indeed, one measure, and I know you were involved in this study, so you're very well acquainted. One measure of significant opioid mu receptor modulation is change in pupil size.
Yes, exactly.
And there was no change in pupil size, and samidorphan combination was used. Mm-hmm. And frankly, there is no change in pupil size with ketamine.
Ah, very interesting. I'll tell you, though, what was shown, though, because I was an author of a poster looking at this issue and looking at possible side effects related to mu agonism, there was a little bit of constipation. That did show up as a signal. So there was a little bit of a teeny bit of a signal, but you're right. Some of the stronger physiologic ones were not there. Okay, let's now move on to some specific newer agents that are in development. And let's start out with GABA-A positive allosteric modulators. This is sort of the analogs of neurosteroids. And one example would be zuranolone. What do we know about the effectiveness of agents like this and the time to response?
Andy, again, a great question, and you probably have more direct involvement in the studies with zuranolone. But here is the idea. Neurosteroids are compounds that are synthesized in central nervous system. They're called steroids because they have cholesterol ring, but they do not act on steroid receptors. As you already mentioned, they're positive allosteric modulators of GABA A receptors. Now, the part that is really interesting is they do not only regulate GABA A receptors that are intrasynaptic. They're the ones that contain alpha, beta, and gamma subunits. They regulate extrasynaptic GABA A receptors, which include delta units. What is the relevance of this? Because modulation of these extrasynaptic GABA A receptors regulates tonic GABA transmission. And if we're thinking about resilience to stress or negative effect, tonic GABA transmission may be very relevant there. And we know that benzodiazepines, aside from very old data related to alprazolam in treatment of MDD, there's really no consistent evidence that benzodiazepines will help with depression.
Right.
On the other hand, you mentioned zuranolone. There are studies with zuranolone that in some ways change treatment paradigm. You asked how long will it take? There's a robust effect in a matter of days. Initial treatment was only 2 weeks long, but about 2/3 of that effect was present after first week of treatment. So this is very clearly different than monoamine modulating medications. And then, of course, the question comes, we get an acute effect. Is that going to last?
Right.
Number one, in phase 2, in early studies, how often did we see remission with zuranolone? It was slightly above 60%. Which was quite impressive in a blinded study. But then in extensive studies, very good, where they used higher dose of zuranolone, 50 milligram dose. What they noted is that between 65 and 70% of the individuals needed only 1 or 2 treatments in a year.
Exactly. Yes.
So would you agree that for majority of these patients, it seems to not only be early effective treatment, but may carry over to where they may not need too many retreatments within the context of a year?
Yeah, so what you're talking about here is not only a new paradigm of a new mechanism of action, but a new paradigm of something called intermittent treatment. And that would be a 2-week course. And as you said, we were surprised. The study you're referring to is called the Shoreline study that I was involved with. And we were surprised at how long it held a charge for how many people. Now, there are some maybe who needed retreatment. And what was interesting was they responded with each subsequent retreatment. It wasn't as if they wouldn't respond a second or third time. So in the real world, of course, we would use this paradigm, and there might be some patients that will learn we have to maybe regularly retreat, maybe quarterly or something like that, or twice a year. So it really is fascinating. Vlad, I've been saying for a while, I think much of our treatment in the real world is intermittent anyway, because patients stop their medicines.
Or patients make it intermittent even if it was not intended.
Yeah, they take it when they feel like they need it or something like that. So, we'll have to see. But it is certainly fascinating that here's a medicine that works rapidly. And if you only have to take it for a 2-week course, you're not going to necessarily have some of the long-term side effects that we see with our medicines, like weight gain, sexual dysfunction, and so on. So that would be interesting. This medication, by the way, they're going to be submitting to the FDA, and this is an oral version, by the way. The first one that was approved was brexanolone, intravenous brexanolone, an analog of allopregnanolone, and that's for postpartum depression. But that's an intravenous treatment, and this is an oral version being developed, which I think is very interesting. They also had a study called the CORAL study where zuranolone was given in combination with the initiation of a traditional antidepressant and versus the antidepressant alone, and they found that the response was much faster. So you can accelerate the response to the antidepressant. So that's another way of thinking about using it, either monotherapy or in combination.
And I believe zuranolone is also now being studied in postpartum depression.
That is true. That is true. And that would be a lot more practical to administer, of course. Okay, next, let's talk about multimodal agents. There's a medicine called dextromethadone or S-methadone in development. Right away, I hear methadone, I think opioid. But is that what's going on with this compound?
No, there are 2 ways that it is mentioned in literature, either as S-methadone or as dextromethadone, and compared to the racemic mix, it has 20 to 30 times less modulation of opioid receptors. So this is medicine that primarily modulates NMDA receptors.
Yeah.
And modulates them in a way that's, let's say, different than ketamine. in a sense that this is very modest NMDA receptor antagonism. And the part that is really intriguing, it's very rapidly reversible. So it hits the receptor, let's go right away. Part that is something that I'm curious about, might that translate into a different, not only therapeutic effect, but side effect profile? Because these folks don't dissociate, right?
Yes. So it sounds like if you block NMDA too strongly, or if you hang around too long, you get the dissociative complications. So if it's like Goldilocks. If you can just block it just right, you don't get dissociation.
Yeah, indeed. And you mentioned how important it is to have a rapid response. This is another one where the response is noted within days.
Yes.
And within a week, it's about 2/3 of the ultimate response occurs within a week. So again, it appeared in the initial studies, and colleagues published a study that is Mass General group. And again, initial study that is randomized and controlled, it looks quite effective. It looks quite impressive.
Yeah, I agree. And they're, of course, in phase 3 development right now. The concept here is almost like an oral ketamine-like drug. And there's another one in development, which is a form of dextromethorphan. And this is a drug called AXS-05. And this is a really, really nifty idea here. This is a combination of dextromethorphan with bupropion, which is an antidepressant that's been around for a while. And this is both a pharmacokinetic and a pharmacodynamic manipulation, right?
Indeed, absolutely. Initially, the idea was to add bupropion because it is a 2D6 inhibitor. So dextromethorphan has very short half-life, would need to be given several times a day, which was deemed to be impractical. So there are 3 types of combinations that have been studied in general psychopharmacology. There's a combination with quinidine that was initially studied. There's combination with bupropion. And more recently, there's a combination with paroxetine to help with agitation in dementia patients. So the principle in all of these is simple. Let's extend the duration of effect of dextromethorphan. But you're making a good point. Bupropion may be bringing something that is beneficial in treatment of mood. Although in the studies, my memory is combination of dextromethorphan and bupropion did separate from bupropion alone.
Yes.
So it is something about dextromethorphan, which in and of itself is a very interesting compound. Please correct me if I'm wrong about this, but this is a serotonin reuptake inhibiting agent.
That's true.
And it is also a robust sigma-1 receptor modulator.
It's a sigma-1 agonist. Yes, you're right. And that is an mechanism, yes.
Indeed, because there is very good evidence that sigma-1 agonism translates into altered trafficking of one of the other glutamate receptors. It's called AMPA receptor. So components of the AMPA receptor become available on the surface of the cell more readily. Stimulation of sigma-1 is associated with increased synthesis of nerve growth factor and brain-developed neurotrophic factor, right?
Yes.
And the last that is not well known, it actually interferes with synthesis of pro-inflammatory compounds. It inhibits nuclear factor kappa beta, and again shifts cells away from their inflammatory mode. So that may be an additional benefit of this medication. And it is also, of course, an NMDA receptor antagonist. Again, much more modest than, for example, ketamine and esketamine. And another one that has a fairly rapid dissociation too.
Yeah, so you've hit the trifecta, Vlad. Dextromethorphan has 3 things going: serotonin reuptake inhibition, sigma-1 agonism, and NMDA antagonism. Again, this sort of oral ketamine-like mechanism. That's fascinating. And you're right that the data also showed efficacy within the first few days.
Indeed. And the part that is really intriguing, if we look at all these compounds, so from ketamine, esketamine, dextromethorphan, dextromethadone, they have greater affinity for NMDA receptors that contain so-called N2B unit.
Yes, the N2B, exactly.
And these tend to be extrasynaptic NMDA receptors.
Yes.
Why would it be relevant? Because it's these extrasynaptic NMDA receptors that modulate other neurotransmitter systems, that modulate astroglial activity.
There you go.
In the nerve cells, extrasynaptic NMDA receptors are the ones that suppress neuroplasticity. So blocking this receptor would increase neuroplasticity. On the other hand, these compounds don't interfere with intrasynaptic NMDA transmission, which tends to be more long-term potentiation versus long-term suppression.
That's important for cognition, learning, memory. You don't want to mess around with that, right?
Exactly.
Yeah. So it's fascinating. So that actually reminds me, Vlad, I want to go back for a second to the GABA A story, because again, you're talking extrasynaptic versus intrasynaptic. And with the neurosteroids, they bind to both the intrasynaptic and extrasynaptic GABA A receptors, which of course are ion channel receptors, as opposed to GABA Bs, which are metabotropic. But the benzodiazepine thing you mentioned, they have a specific binding site at the intrasynaptic GABA A. So the neurosteroids, while they're working on the same general receptor as a benzodiazepine, they're not benzodiazepines, and they're binding to a different site, to a different place.
You're absolutely right, because benzodiazepines are more likely to modulate phasic signaling, so bursts of GABA in response to, let's say, some adverse event. On the other hand, extrasynaptic GABA A modulation conducted by neurosteroids and also positive allosteric modulators of GABA A regulate more phasic, sustained balance between inhibition and excitation.
Yeah, I think this is an important concept for our audience to understand, since we've now talked about intrasynaptic receptors versus extrasynaptic in two different systems, the GABA A and the NMDA system. So that's really interesting to think about it, and that you can actually have drugs that specifically target not just GABA A receptors in general, but specific ones, or not just NMDA in general. And so NMDA receptors are not all the same. That really allows us to be a little more precise in our targeting.
Absolutely.
As opposed to our monoaminergic agents are such blunt instruments. If you're blocking reuptake, you're just flooding the brain with serotonin or monoamines, and you get a lot of collateral damage. Right?
And absolutely no regional specificity.
Yeah.
We modulate serotonin receptors in retina. Serotonin is involved in so-called visual editing. And if we overdo it with SSRIs, patient develops something that's called polynopsia, a side effect where if there's a light object moving in front of the dark screen, it seems like a comet. It seems like it has a tail. Serotonin, when it comes to auditory processing, regulates how we hear sounds. If there is disturbance in serotonin signaling caused by higher doses of SSRIs, people may have ringing in their ears. Let alone peripheral impact on gastrointestinal function, on clotting and platelets. So absolutely no regional specificity, not even specificity in terms of does it work in brain or the periphery. I would say major advancements.
Yeah, so some of the same neurotransmitters work throughout the body, not just in the brain. That's fascinating.
Yep.
Let's shift gears and talk about the only one of these so far that is FDA approved or that is well established clinically, and that would be the ketamine and S-ketamine.
Indeed.
And how safe and effective are ketamine and S-ketamine, and how fast do they work?
I would like to point out ketamine is FDA approved, but as anesthetic. Right, ketamine is approved for treatment-resistant depression and major depressive disorder associated with suicidal ideation, so two separate indications. There is robust evidence. Obviously, you and I have had many conversations. A robust evidence of efficacy of intravenous ketamine infusions for ketamine. Abrupt onset. The only drawback, I would say, is that we really don't have too many long-term studies. The studies are usually measured in weeks, and therefore, long-term efficacy and safety and optimal protocols are not as well established. With S-ketamine, we're in a very different shape because not only do we have acute studies, we now have long-term studies that extend to 4 years out. So we know much more about safety. I don't know if you would agree with that.
Yeah, I would agree. And I think, first of all, let's back up and say ketamine is a racemic mixture, of course, of R and S-ketamine. And S-ketamine is then one of the isomers. And the other big difference is ketamine can be delivered many different routes, but traditionally is given intravenously, whereas the S-ketamine is an intranasal preparation. Ketamine has been studied as monotherapy, whereas the S-ketamine was studied and is approved for use with a traditional antidepressant, although there's no reason to think that it might not work as monotherapy because ketamine certainly does. But I agree with you that we have a lot more data on the S-ketamine, that a pharmaceutical company actually really stepped up to the plate and sponsored these very large studies. And the fact that ketamine is generic, nobody's really funding those kind of studies for it. So we have issues, of course, with ketamine and S-ketamine as far as the most appropriate way to use these medicines. How long does somebody have to take them for? How frequently should they get?
Indeed.
We do have some guidance for S-ketamine, as you mentioned, but not so much for ketamine. This leads to the issue of what's the best way to utilize these agents as far as how often to give them, how long do we give them for? Does somebody need to keep taking them indefinitely? And if so, can we give the treatments more spaced out? Because ketamine appears to only hold a charge for a week or two. You have to give it weekly or every other week. So there's a lot to be worked out. Our really good friend, Roger McIntyre, was a first author recently on an amazing international panel of experts on some guidelines for the use of ketamine and S-ketamine. And Stephen Stahl was the final author on that paper.
I agree with you. Those are very important guidelines because they in some ways provide guardrails. Right. They inform us about the relative efficacy of racemic versus the S-ketamine. They also provide a lot of information about how these treatments can be safely used and how to appropriately monitor treatments with S-ketamine and racemic ketamine. Yeah. So I think very useful guidelines.
Yeah. Now, of course, the intranasal S-ketamine being FDA approved, we have very good information on how to use it. It has to be given in the clinic. It's self-administered. We have protocols for how to do it. We have a REMS, risk management program, but we don't have any such things for ketamine, intravenous ketamine, and yet these intravenous ketamine clinics are popping up like mushrooms all over the place. And my worry is that they may not be following these guidelines that Roger and Steve published.
Andy, they may not be following guidelines. And then there are studies that looked at prediction of response or negative predictors of response, so non-response to ketamine. And indeed, if individuals within the first couple of weeks do not benefit from ketamine, the odds are minimal that they will start benefiting from it later on. Mm-hmm. And some of these clinics just keep on going because unfortunately there's commercial gain to extend the treatment.
Yes, certainly true. And then often they're run by anesthesiologists, and the participation by mental health professionals is very variable amongst these clinics.
Indeed. Indeed.
That's certainly a problem. What do we know about the effectiveness of racemic ketamine versus S-ketamine, and why might it be reasonable to think there might be a difference?
You mentioned our friend Roger McIntyre. There's a paper which was published where he's one of the co-authors. And indeed, slight benefit favoring racemic intravenous versus intranasal S-ketamine. Mm-hmm. But yeah, I would say more head-to-head and especially more extended treatment studies would be beneficial. Yeah. Because it's always a balance, right? It's what we get in terms of acute benefit, how well it's sustained over time, and how it balances with adverse reactions and risks.
Now, of course, there are many examples of racemic medicines where one isomer is doing the heavy lifting. But in this case, both R and S are active, and they actually have slightly different things that they do. Isn't that right?
Absolutely. And there are some studies underway with R-ketamine. There are Japanese authors who believe that these will be beneficial. I think that S-ketamine was utilized because it has much greater potency at NMDA receptors. But yes, I think we just need to see the work and get a little bit more information.
Yeah, the S-ketamine is more potent, which means that you can give it in a smaller fluid volume as opposed to a large intravenous bolus. This allowed for the intranasal preparation, and I think that is a lot more convenient, of course, than an IV bolus. Mm-hmm. But there is evidence, isn't there, that the R isomer may be a little more working on AMPA system? There's all kinds of preclinical suggestions of what each of these does differently, but it's possible the whole is greater than the sum of the parts.
Right.
And also there's evidence that some of the metabolites like HNK, hydroxynorketamine, may be doing some of the lifting here too.
Indeed. The Asian authors are doing these studies right now. And yes, I look forward to seeing not only preclinical studies, but I look forward to seeing human data. And adequate human data are lacking right now.
Absolutely. So it's a very exciting time here. Let's talk about something else that very recently you and I have become aware of, and that is there are a number of studies now looking at the efficacy of ketamine, usually IV ketamine versus ECT.
Indeed. So there are two studies. There is a Nordic study that had close to 190 patients, and there is another study, I believe French study, that had only about 50 patients. And these studies did not have consistent findings. Nordic Scandinavian study indicated that ECT has substantial advantage over ketamine in treatment of depression. The other study did not find a significant difference. The obvious problem is, how do you blind these treatments?
Right.
Right, because ECT is not easily blinded. There are studies with sham ECT. I don't know how convincing it is. And there are studies using Midazolam as a way of blinding ketamine. However, we don't know what patients' expectations are. We don't know if patients, if they're receiving ECT, they believe that this is going to be more robust treatment, and therefore this implied placebo effect is greater with one versus another. We really don't know. Right. It's interesting. I would not be surprised if indeed ECT has some advantage over ketamine, but I would say that we still don't have the final word.
But that's not to denigrate ketamine. It's not to say ketamine doesn't work. Certainly.
Not at all.
And ECT is not universally available, so there are situations where you might have access to one and not the other. So again, I think it's just great to have options to have this.
And adverse reactions of ECT, I don't want to overstate those, but there are sometimes sustained cognitive effects. What we know with well-conducted S-ketamine and then ketamine trials, if appropriately used, there doesn't seem to be any detrimental impact on cognition. If anything, it may even enhance it to a degree.
That's right. And so there are some side effects that particularly around the time of administration, but as far as long-term issues, they don't seem to have it as much as ECT might.
Exactly.
Certainly interesting. Let's shift gears for just a second, if we could, and let's talk about psychedelics. This could be a whole podcast in and of itself, and we are getting short on time. So let's just talk briefly about what we know about psychedelics so far, which ones are being studied, what data we do have.
I would say that we probably have, I don't know if you would agree with me, most data with, there are two, psilocybin. Yes. And on the other hand, not so much for controlled studies, but there are some data on LSD. And the data with LSD are mainly large epidemiologic studies showing that it's associated with less suicide attempts. When it comes to psilocybin, we do have some controlled data where escitalopram was one of the controls.
That's right.
There's also a study where waitlist was used to control. It's, I believe, a Johns Hopkins study.
That's right.
In Johns Hopkins study, obviously, use of psilocybin was much more effective in reducing symptoms of depression, being on the wait list. Interestingly enough, escitalopram, when it comes to primary measures, escitalopram versus psilocybin did not demonstrate on primary measure a difference between the two. But on the other hand, it is also a question of how we measure improvement in depression. In the sense that if we look at feeling at one with the world, if we look at expanded insight on some of these measures that are not typically captured by depression scales, there was a difference favoring psilocybin.
Makes sense.
So it may have different effects and effects that are not necessarily captured with standard scales.
Vlad, what's fascinating to me is, doesn't escitalopram indirectly activate 5-HT2A receptors if you're raising serotonin?
Indeed, you're right. There's an overlap. You're right. These are not completely separate interventions. You're absolutely right.
Yeah, but I suppose you're not just doing that. Of course, when you're raising serotonin everywhere, you might be balancing out some of that and countering some of that out. Whereas with the psychedelic, you're more specifically targeting that one receptor in a more potent way. So it is fascinating, again, to think about.
Interestingly, Andy, we were talking about brain networks.
Yes.
And we were talking about strengthening brain networks with psilocybin. That phenomenon was not observed with escitalopram in the study.
There you go. So there's something about that, being more specific and targeted. So psilocybin has received breakthrough status from the FDA for the study of depression. Psychedelics are being looked at for many other conditions such as PTSD, I know, and anxiety and some other things as well. So they're very hot right now. There's a degree of faddishness, a fad going on here with them, I believe. One of the interesting controversies is, do you need the hallucinatory experience, the psychotic experience, or the psychedelic experience to have effectiveness? Or is that more of a toxicity, and that really activating 5-HT2A is the issue, or strengthening these networks, and that you don't require that experience?
It's interesting. At this point, there are over 120 entities that are doing studies with psychedelics and MDD.
Yes.
And there are a number of these early phase studies that are looking at serotonin 2A agonists that are not psychedelic, they're associated with psychedelic experience. I guess we'll have to stay posted and see what the findings are.
Yeah, there's something that are being called second generation or newer psychedelics, if you will, that are derived from some of them that don't have that psychedelic experience.
Indeed.
And so you're right. We'll have to see. It's an exciting time. I think let's wrap up with, how do we implement some of these options? In other words, this is a real paradigm shift now for us and for our patients, and certainly our expectations are going to change. And of course, as we talked about, the way we deliver these treatments are different. This is not just, I'll write you a prescription for a pill and I'll see you back in several weeks. Some of these require intervention at the clinic level and such. How do we think about now trying to implement some of these strategies? What are our expectations? What do we tell our patients to expect? That kind of thing.
Andy, before we go into our algorithm for psychopharmacology, I would like to mention something that may be a little bit more like grandma's chicken soup.
Okay.
And that is that some of the reasons why antidepressants don't work is not necessarily pharmacologic reasons. There are very robust studies showing that individuals who have had early life adversity or history of abuse don't respond to antidepressant pharmacologic treatments as well. There is a very interesting study that looked at satisfaction with marriage and how it impacts response to 6 to 8 weeks of antidepressant treatment. They compared top third, the most satisfied individuals with their marriage, versus bottom third, the least satisfied. Satisfaction with marriage increased response and remission rates by 100%. So it doubled the response and remission rates. Wow. In other words, let's not try to treat bad marriages with antidepressants. And finally, this is a very large study, and I think it's worth taking into account because it included 300,000 individuals.
Oh, my.
They were evaluating so-called polygenic risk scores. So we know that there are several dozen genes that are involved in propagating risk for major depressive disorder, and they all have minuscule effect. But we can count them up and come up with an index that is called polygenic risk score. So this is quantification, genetic quantification of the risk for MDD. So in this particular study, they looked at individuals who had the top third polygenic risk score. So genetically, they were the ones who were most predisposed towards having MDD. And having this high risk translated in only about 22% more chance of having clinical depression. But here's the kicker. They also looked at lifestyle factors. So one was a moderate alcohol use, which is about 1 glass of wine or 1 beer a day. BMI less than 30. Healthy diet, which means 2 changes: more fresh fruit, more vegetables, more fish, or less processed meat and red meat. They also looked at the changes in physical activity, very mild expectations, moderate activity, walking 150 minutes a week. So 2.5 hours a week, or more vigorous activity, just 75 minutes a week. And guess what it showed? Individuals who had high risk but engaged in all 5 of these modifying activities, compared to individuals who had high risk but had 0 to 1 of these modifying activities, the risk of developing depression changed tenfold.
Oh, my goodness.
So, yeah, isn't it? So in other words, even if one has very high genetic risk, but lives healthier lifestyle, we can very substantially reduce the risk. So how it corresponds with your question, what I'm saying, yes, we need to think about pharmacologic algorithms, but let's first put emphasis on what is going on in persons' lives. What are their relationships like? We know that loneliness increases the risk of depression.
Yes.
And number two, what are they doing to maintain their health? Is there past trauma, early life adversity that could influence our treatment choices? And only when we have considered all these not pharmacologic factors, then it's a good idea to say, okay, if the first antidepressant is not working, where do we go? And my sense, based on our conversation so far, Andy, is we need to move medications that have alternative modes of action, such as glutamatergic and GABAergic transmission, earlier in the algorithm. But in order to do that, I think we need more data.
I would absolutely agree. And what you're making me think, of course, is the concept of epigenetics, that, in other words, our genetics, we're not just doomed to our genetic code, if you will, but that these things, the transcription of these genes can be modified through all of those ways you're talking about. And we know that early life adversity leads to permanent epigenetic changes in transcription. And so this is why it is so important. I'm so glad you brought this up, Vlad, that we think about treating depression holistically like we would any illness. With diabetes, Vlad, I wouldn't just give you insulin and let you eat all the chocolate cake you want and let you be sedentary. And cardiovascular disease, the same thing. So we really should be looking holistically to get the best outcomes. And some of these things are such low-tech interventions, the things you've mentioned, that can easily be incorporated into someone's lifestyle. So with that, I do want to say one thing. You mentioned genetics. I just have a quick question. I get asked this question a lot, as I'm sure you do. Can pharmacogenetic testing be useful in helping us pick antidepressants? I realize that's another podcast in and of itself.
Right.
Just briefly, let's mention that.
And please, I would like to hear your response to that question as well. But my reading of literature suggests there are some studies indicating that pharmacogenetic testing was advantageous. On the other hand, the control cohort did not have any kind of algorithm-guided treatment of MDD. So we still don't have studies where they would compare if there's an algorithm-guided treatment of MDD versus pharmacogenetic testing, would there be a difference? So that is not established. But here's what we know. Obviously, there are genetic tests that will identify activity of some of the metabolic enzymes. And there are ultra-rapid metabolizers versus slow metabolizer can result in multiple differences in blood levels of certain antidepressants. And it is definitely good to know if there may be genetic factors that impact on metabolism of various antidepressants, so we can choose the more favorable categories. In the past, there was some suggestion that, for example, MTFR gene may influence response to L-methylfolate. Unfortunately, meta-analysis did not bear that out. There is one of the genes that does regulate metabolism from dietary dehydrofolate to L-methylfolate, but it's not MTHFR gene. And it's not the one that shows up consistently on the genetic panels. So I would say there may be, but standard panels are, in my mind, mostly helpful determining which metabolic pathway is to be avoided or is more appropriate for antidepressant treatment.
Yeah, I would agree. I think the current panels are better for pharmacokinetic information than pharmacodynamic. And so maybe more helpful with a dose or a drug interaction than with selecting the actual antidepressant that has a mechanism that's more likely to work. There are a couple of exceptions. You mentioned the methylation situation. There is, of course, the short versus long arm of the serotonin transporter, which unfortunately is not panned out to be a perfect measure. In other words, traditionally we were told that if you're homozygous for the short arm of the serotonin transporter, you won't respond to an SSRI. That's not true. You're just less likely to respond.
Indeed. You have more side effects with short version.
That's right.
And interaction between short version homozygous individuals with stress. Unfortunately, these large genome-wide association studies did not bear that out.
Yeah. Now, one gene that I find fascinating, of course, is the COMT, the catechol-methyltransferase, which is an enzyme that breaks down monoamines, but predominantly dopamine, And it's interesting, usually when you have a mutation, you render the enzyme less effective. In this case, the mutation makes turbocharges the COMT, and so you chew up dopamine faster. Right. And I've always wondered if people with that mutation might not need a dopaminergic intervention, such as an amphetamine or something like that. It hasn't really been proven yet. We need more data, as you said. One thing I can say is these panels are evolving, and they're always adding to them, and I think ultimately there may be more utility to them. I think at this point, it's limited utility in the ways we've talked about.
Indeed, Andy. And the part that is really interesting, if we look at individuals with major depressive disorder, by and large, they will have more rapid turnover of monoamines. So I'm talking about serotonin and norepinephrine and dopamine. So metabolite levels actually may be higher in these individuals. And successful treatment is actually very often associated with normalization of metabolites with lower turnover, which means more efficient signaling.
Fascinating. Well, unfortunately, I can't believe how fast the time has passed, Vlad, but we've run out of time for this version of our discussion. I'm certainly hopeful we can continue this discussion in the future, but I really want to thank you so much, Vlad, for your time today. Thank you for joining me.
Thank you, Andy. Like always, it is always very enjoyable, and I always learn a lot from conversations with you.
I would say the knowledge transfer is not only bidirectional, but tridirectional. Not only are you and I learning from each other, but I'm sure our audience, and I certainly hope our audience has learned something, and hope that they're sharing in our enthusiasm for these novel mechanisms in development and the new era we're entering, and the fact that we need to think about how we're going to implement these treatment modalities in our clinics and what kinds of expectations as far as onset of efficacy and also different side effect and risk profiles with these agents. I want to thank you very much for listening to this NEI podcast. I also want to remind you that you can go to our website to hear about our other educational offerings, and the website is www.neiglobal.com. And you can catch all of our other podcasts. We have many podcasts, both CME and non-CME, and you can catch those wherever you get your podcasts. So again, thank you, Vlad, and thank you for listening. This is Andy Cutler signing off for now.
Thank you for your participation in this NEI CME podcast episode. To receive your certificate of CME credit, please refer to this podcast's subscription page for a link to go online and print your certificate. This concludes the CME podcast presentation.